Hi, welcome back. So we're going to continue our USMLE series. We're starting with pathology. So we're going to continue with cellular adaptation. Last time we spoke about hypertrophy, so now we're going to talk about hyperplasia. So just with every conversation, we start with questions. So the first question, 70-year-old man present with dyspnea, angina, and syncope, right? Those are the sad symptoms that we classically see in aortic stenosis. So on examination, there's a crescendo decrescendo systolic murmur at the right upper sternal border radiating to the carotid. So that also further supports the sad symptoms that we see with symptomatic aortic stenosis. Echocardiography shows calcification of the aortic valve. Which of the following is the most likely pathophysiologic consequence of this valve disease? So the likely answer there will be A. So pressure overload of the left ventricle leading to left concentric hypertrophy. So with aortic stenosis, that could increase the left-sided afterload, and because of the increased afterload, then that will lead to left ventricular hypertrophy, similar to what we see with long-standing hypertension. So some extra point for us. So with calcification of the aortic valve, who can tell us what pathology process can lead to this calcification of the aortic valve? Yep, dystrophic calcification. So whereby there is a deposition of calcium in abnormal tissue, maybe because of necrosis or inflammation of those tissue. Next question. A 32-year-old woman presents with excessive menstrual bleeding. So she comes with menstrual bleeding. We did endometrial biopsy that showed increased numbers of endometrial glands relative to the stroma, preserved cell polarity, but no atypical cell. Which of the following best describes this process? So this is going to be a classic case of hyperplasia. And just some extra bonus question. So this patient has endometrial hyperplasia. So what's the risk if this endometrial hyperplasia is not addressed? What can it lead to? Yep, so it can lead to dysplasia. And then with dysplasia, that's when you start to see what? Atypical cells. And if that's not addressed, that could lead to endometrial cancer. Moving on to the next one, the last question. A 62-year-old man presents with difficulty starting urination and increased urinary frequency at night. So that sounds like a perfect age, right? With somebody that is having urinary symptoms, especially at night. So that sounds like symptoms of BPH, right? Benign prostatic hyperplasia. So they did a dictal rectal examination that reviewed symmetrically enlarged non-tender prostate. Transrectal ultrasound confirms a diffusely enlarged prostate gland. Histology demonstrates an increase in the number of both glandular and stromal cells, but the architecture is preserved with no atypical cell. Which of the following best describes this process? So this patient has, like we alluded to, have benign prostatic hyperplasia due to the effect of androgen stimulation. And just some extra points. Anybody know which type of androgen? Yep, DHT, dihydrotestosterone. And the last question is BPH a risk factor for prostate cancer? Yep, no. So BPH, benign prostatic hyperplasia, is not a risk factor for prostate cancer. Good job, guys. So let's talk about hyperplasia. So hyperplasia is a reversible increase in the size of the cell due to increase in the cellular number. And hyperplasia and hypertrophy sometimes can occur together and occurs in what we call stable and labile cells. So stable cells are cells that they are always in the GO phase, but if something stimulates them, they can go into the cell cycle and they can divide. Whereby labile cells are always in the cell cycle constantly and dividing. And hyperplasia could be physiology or pathology adaptation. So let's look at the mechanism. So there's a particular stress, right? The stress is placed on the cell, and that causes gene activation, release of growth factors, and a cellular division. And don't forget, so the buzzword in hyperplasia is increase in the number of the cells. So increase in the number. Remember, as opposed to hypertrophy, increase in size. So let's go through some examples of hyperplasia. So the first one is related to hormonal stimulation. So first example there is breast enlargement during puberty and pregnancy due to the effect of estrogen and progesterone. Another example is also intraductal. So that would be a classic physiology example. Intraductal epithelial hyperplasia in patient with fibrocystic change of the breast, also related to hormones like estrogen. Endometrial hyperplasia due to increased exposure to estrogen. So estrogen could be maybe a classic case of a patient who have polycystic ovarian syndrome, whereby they're exposed to too much of estrogen. So that could cause endometrial hyperplasia. And like we mentioned earlier, this could lead to dysplasia and that could lead to endometrial cancer, right? So if you see a question, somebody who is postmenopausal and start having vaginal bleeding. So postmenopausal vaginal bleeding should raise a concern for endometrial dysplasia or cancer. So that patient might need endometrial biopsy. Moving on to benign prostatic hyperplasia. So this is due to increased stimulation by dihydrotestosterone. But remember, no increased risk for prostate cancer. Next one is red blood cell hyperplasia, which from increased exposure to erythropoietin, right, which is the hormone that stimulates the bone marrow to make more blood cells. So this could be due to somebody who is taking exogenous use of erythropoietin to be able to enhance their performance, or it could be due to endogenous production, maybe as a result of hypoxia, because we know hypoxia is what can stimulate production of erythropoietin from where? From the interstitial cells in the peritubular capillary in the kidney. So that's why patients who have kidney failure, they could have anemia. And then we also have some certain tumor that are making this erythropoietin, like renal cell carcinoma, hepatocellular carcinoma, pheochromocytoma, uterine fibroid. Those could make erythropoietin, and that could lead to red blood cell hyperplasia. Moving on, infection. So example like human papilloma virus causing epidermal hyperplasia, which we see as genital or anal or oral warts. We could also have regenerative hepatic nodules in the setting of hepatitis B and a C infection. And this could also be a risk factor for, it can lead to dysplasia, and that could lead to hepatocellular carcinoma. Moving on to irritants. So regenerative hepatic nodules due to free radical injury from iron copper, right? Iron and copper through Fenton reaction, which we're going to talk about later, they could generate hydroxyl free radicals. And these hydroxyl free radicals, they could target the DNA, they could damage the cell membrane, and that could lead to what? Free radical injury. Also, of course, if somebody is drinking, that could also lead to damage to the liver, and that could lead to regenerative hepatic nodules. Also, epidermal hyperplasia in somebody who have eczema, whereby they just keep scratching the skin. In patients with atopic disorder, so that we could also see hyperplasia in them. And the last example there is bronchial mucus hyperplasia, which could be seen in the setting of smoke exposure or hyperactive airway disease in patients who have asthma. Remember, bronchial mucus hyperplasia is one of those pathology findings that we see in the airway of patients with asthma. Moving on to hyperactive gland enzyme or element deficiency. So the first one there is thyroid hyperplasia in the setting of Graves' disease. Graves' disease is an autoimmune disease that causes hyperthyroidism that is producing thyroid-stimulating immunoglobulin. And those thyroid-stimulating immunoglobulin, they're stimulating the thyroid gland to make more thyroid hormone, and that could lead to thyroid hyperplasia. And remember, this antibody, they are what? IgG. And moving on to parathyroid gland hyperplasia in the setting of end-stage renal disease, because with end-stage renal disease, you can have hypovitaminosis D because you can't do the second hydroxylation of vitamin D in the kidney. And also, you can't excrete phosphate, so they could have hyperphosphatemia. So as a result of that, the body wants to increase the parathyroid hormone production to be able to increase your vitamin D and to get rid of the phosphate. So as a result of that, that could lead to parathyroid gland hyperplasia. And the other one is also hypocalcemia. So if somebody have hypocalcemia, that could also lead to parathyroid gland hyperplasia. Also, beta cell hyperplasia in fetus of a diabetic mom, right? So because with diabetes, if the mom is diabetes and she's pregnant and the diabetes is not well controlled, the glucose could cross the placenta, and that could lead to fetal hyperglycemia, and that could lead to insulin production. And guess what? And guess where is the insulin coming from? Beta cell. So that could lead to beta cell hyperplasia. Can somebody tell us what are the other effects of increased insulin in the fetus? Yeah, it can inhibit surfactant, and by inhibiting surfactant, that could predispose them to neonatal respiratory distress syndrome. Also, adrenal hyperplasia due to congenital adrenal hyperplasia due to enzyme deficiency, enzyme like 21 hydroxylase deficiency. And the last one there is thyroid hyperplasia from iodine deficiency. Moving on to others, which is the last example we have here. So the first one there is compensatory nephron hyperplasia after unilateral nephrectomy. So if you remove one kidney, the remaining one kidney that is there, there's going to be increase in size, which is compensatory nephron hyperplasia. And then the last one there is regeneration of hepatocytes after partial hepatectomy. So if somebody had removal of part of their liver, the remaining part of the liver could grow back. And the way they're able to grow back, because they are stable cells. So because they are stable cells, they can go into the cell cycle, divide, and that could increase their size back to normal. And I think we've come to the end of today's video. Guys, don't forget to subscribe and follow us on our social media platform, and I will see you in the next video.